it's a little intimidating to come talk to an entire room of experts about Dravet syndrome, because you guys live with this condition in your homes, and you know far more about it and about the real faces of Dravet than we do when we just work in this field. And so I very humbly will try to tell you some things about Dravet, and I'm concerned that most of you already know all this stuff, and I know that you have an entire other perspective or additional perspective to add on to that. But with that said, let me start talking. And really, I'm going to address today just kind of an introduction to Dravet, specific to the diagnosis and treatment of Dravet syndrome. So, has anybody, I know Guida has met Charlotte Dravet. Yeah, she's great, right? She's so warm and so motivated, loves coming out to speak with families. And she's just a great person to have a condition named after. You know, sometimes like some of these medical conditions that are named after people, and then you find out it's because they like discovered it experimenting in World War II or something like that. No one wants to use the name anymore. But in this situation, really, she's just a lovely person, and it's great that she's able to have this condition named after her. She first called it severe myoclonic epilepsy of infancy, as you know, and that was in 1978. But really, what they kind of discovered over time was that that description isn't really very descriptive, is not wholly descriptive, as I said there. I mean, for me as a neurologist, I would think, okay, so there's our little babies, and I have to look for myoclonic jerks. Well, as you all know, Dravet syndrome doesn't start in little babies with myoclonic jerks. Infancy, by definition, is under the age of 12 months. So that's not typically how it starts, and so that wasn't really very helpful. So it kind of got renamed in 1989, Dravet syndrome, and then unlike how we're going, where we're trying to go back to descriptive terms rather than eponymous terms, we're actually kind of quite motivated to keep the eponymous term here, not just because she's so lovely, as I said, but because it's a better fit than severe myoclonic epilepsy of infancy. And I think that SMEI thing just confuses my med students and residents. It's because it doesn't really make sense. The incidence ranges from about 1 in 15,000 births to 1 in, I think there was something that said 50,000 births. Probably the best study says about 1 in 40,000. So that's an incidence. So that's not how many people are living with it at any given time. That's for every new child that's added to the earth. 1 in 40,000 supposedly will have Dravet syndrome. And the biggest take-home message about the diagnosis, at least historically, and I hope this is changing, is that the diagnosis is very commonly delayed. And I'm sure every one of you could give me a story about that. You know, in Elaine Worrell's study published in 2013, where she looked at stiripentol use, but they gathered all sorts of data about their cohort of kids with Dravet, their average time to diagnosis from first seizure to families being told the child definitively had Dravet was almost 5 years. So I have to say that's not wholly surprising to me, but that is a long time. And there was a study out of Norway, a smaller study, with 7.4 years. So it's not just like a US-based problem, and I'm sure our data in Canada would be similar. And the reason for that, to be fair to my colleagues who are seeing children with seizures, is that it can actually be quite tricky to diagnose. There is a very characteristic story for Dravet syndrome, as you know. Characteristic presentation, meaning like how kids look when they have it and what story they tell to the doctor. But healthcare providers need to think of it. So actually awareness as far as Dravet goes is really important, because if they don't think of it, they're going to give another diagnosis to those kids. And there's actually, I think it was in Elaine's 2013 study, where she kind of lists the other conditions that kids have been misdiagnosed with. And I can totally see that. Lennox-Gastaut, different types of epilepsy syndromes. It makes sense because there are some similarities. The other thing is that in older children and adults, the phenotype, meaning the characteristics of the disorder, are quite less characteristic or less stereotyped, especially if you don't go back and get the early history. So I didn't know that Danielle had Dravet. I inherited Danielle when she was, what I mean is I took over her care from someone, maybe Dr. Logan, when she was already a little bit older. So I didn't know her through kind of the time when she was doing the typical Dravet story. And then if you don't go back and ask that story again, and doctors meet people with Dravet in their teen or adult years, the diagnosis is very commonly missed. I think that's going to change as we get more genetics, but so that's the reason for the delayed diagnosis, but I think there's things we can do about it. A lot of what I'm going to talk to you about today comes from this brand new manuscript that was just published in Pediatric Neurology. I was very grateful to be part of this. I just want to tell you a little bit about what we did. So we put together a panel, and Dr. Andrade, who's going to talk to you later as well, was part of this project. We put together a core panel of 6 pediatric epileptologists and 2 parents of children with Dravet to come together to try and come up with recommendations on how to diagnose and take care of people with Dravet syndrome. And the core panel then recommended other neurologists and other family members from around North America, and we came up with a final expert panel. You can see there we had 14 physicians and 5 family members on the final expert panel. And then we used a literature review, so a really aggressive look at everything that's been published on Dravet syndrome. And we developed questionnaires with statements and questions, and we put them to the panel. So it would be something like, children with Dravet have a history of febrile seizures. So let's say that would be like a line in the questionnaire. And then everybody on the panel, the family members and the doctors, had to say, I believe this strongly, I believe this a bit, or I don't believe this at all. So we kind of endorsed the statements that were on the questionnaires. And then we used something called a Delphi approach, which is a way of getting people to agree on things, basically. It's like a round robin going back and forth, like an iterative process to develop the consensus recommendations. And the reason you have to do something like this rather than just go to the literature and report what's in the literature is because sometimes there's no answer in the medical literature. Not everybody's looked at these questions with good quality studies. So there is another way to do guidelines or recommendations in medicine, and that's the way that they do them for like something like, when should you have surgery for a blocked artery in your heart? Because there's like these massive studies of stuff like that, right? Like, I don't know, 20,000 people who have heart disease, and then they do surgery and they try and figure it out. But for some of these more rare conditions, we don't have big studies like that. So we can't always depend on just what do the studies show. And I'm sure you can all appreciate that a lot of the decisions we make about people living with Dravet are based on the opinion of the people that you've sought out, doctors, other families, nurses, whoever your team is. And so we put together what we think is an expert panel, and it's a combination of the literature and the expert opinions. So throughout the talk, I'm just going to talk about some of our conclusions because I thought it'd be silly to come up here and give you my opinion when I can give you an expert panel opinion, one of which was mine. One opinion in there was mine. So I want to start with diagnosis, reminding you, of course, that we talked about how diagnosis can be tricky. And one of the things we did in that paper that I've just described is there's a really nice table that outlines how do we recognize Dravet in young children. And we listed a series of points. I've consolidated them into 6 points here. And these were all things that our panel thought were strongly characteristic of Dravet syndrome. And I'm hoping that most of this will resonate with you. First of all, that the typical onset of seizures is between 1 and 18 months. That's pretty broad, but you could say under the age of 2 years. In children with normal development at that time, normal MRI, and normal EEG. That's why it's hard to diagnose Dravet, because how many people get sent home with a diagnosis of a febrile seizure, right? And at that time, that's essentially what it is. And it's not until it evolves that we come to understand it better. And then we start to see recurrent generalized tonic-clonic or hemiconvulsive, so shaking of half of the body seizures. And you need to have those recurrent tonic-clonic or hemiconvulsive seizures to make the diagnosis. They're often, but not always, prolonged. So the team didn't think that they had to be prolonged to meet diagnosis and to make people suspicious of a diagnosis of Dravet syndrome. Myoclonic seizures are typically seen by the age of 2 years. And then something called obtundation status, which is, I don't know if people know that term. It's a term that we use a lot in this paper, but it's basically status epilepticus, where rather than having the shaking type seizures. You've maybe seen it where kids are just kind of like out of it, maybe having like little blinking type things. So not big shaking, but for it can be a long period of time. I've certainly had children come into clinic who've kind of been doing it for a couple days at home. There's at least one person here nodding where they're just kind of less responsive, in and out of little seizures that might be absence seizures or flurries of myoclonic seizures. So episodes of that, obtundation status, focal dyscognitive seizures, which is partial seizures where they're not paying attention. That's what the dyscognitive thing means. It means altered consciousness. And atypical absence, which look like staring spells, are typical but usually happen later, after 2 years of age. What we call typical absence seizures and epileptic spasms are atypical, so that helps the doctors, the clinicians, and the doctors and nurses to say, if I see that, this is less like Dravet. And then, of course, the most common trigger is hypothermia, being hot, raised body temperature. But there are some other triggers which are less common but can occur, including flashing lights, seeing certain visual patterns, being in the bath, people reported eating, and overexertion. Of course, the overexertion and the bath can go with the raised body temp, right? Because obviously those are warm situations. So since these are expert panel kind of consensus on how you recognize Dravet in a young child, I hope that this makes sense to you and resonates to you, because this is what made sense to our expert panel of physicians and parents. And there has been an effort towards kind of developing a screening tool. This is a paper that was published in 2008 coming out of Japan, where they actually proposed a risk score, like a screening test for Dravet. And a lot of that stuff is on there, right? So they said that they should start under 7 months of age. They should have had 5 or more seizures. That should include hemming convulsions, focal seizures, myoclonic seizures. And they have different like points associated, and they said that in their opinion that if they had, and from their data, that if you had a score of, I think it was 6 or more, that would suggest that you would have Dravet syndrome. One of the challenges with this, of course, is that, I think what we're looking for is clinical details that help to direct us towards genetic testing or specialist referral from a pediatrician. And so giving scores to the genetics if you have the genetics, then I guess you don't really. So to me, putting the genetics in a risk profile isn't really helpful, because I think what you want is a risk profile that can be applied by more primary care physicians who then can decide to send for specialist care or get an opinion on the telephone, whatever. But there is an effort towards this kind of thing. So how about diagnosing Dravet in older kids and adults? And Dr. Andrade, who's I think speaking right after me, and is a friend of mine, is an absolute expert in recognizing Dravet syndrome in young adults. And she we transfer care of a lot of our patients with epilepsy to Dr. Andrade. But the panel also came up with characteristics of what Dravet can look like in older kids and adults, and you can see it's less tight, but for sure people need to have persistent seizures, and they list kind of many types of seizures there. It's noted that status epilepticus and obtundation status are less frequent in adolescents and adults, as is hyperthermia, high body temperature, as a seizure trigger. It's noted that seizures can be made worse by medicines that act on the sodium channel. So that includes things like carbamazepine, oxcarbazepine, phenytoin, and there's a family of those drugs, and some of you probably know that. There is, in the older kids, the presence of an intellectual disability in most cases, and abnormalities on neurological examination. And I think this is really where Danielle has a lot of experience and has become quite an expert in recognizing the gait and the way people with Dravet, young adults with Dravet, move as a trigger. And she's taught me that when we see that, we should be thinking of Dravet syndrome. And now that I know that, I watch kids as they get older who I know have Dravet, and I'm looking for that. Still, the MRI is usually normal. The MRI brain is usually normal. And the EEG can be a clue. For those of us that read EEG, there's some tricks in there. The MRI can show some non-specific findings. Sometimes we can see the brain get a bit smaller over time, but it doesn't really help us, because in a child or a young adult who has lots of seizures, we can see these subtle changes in MRI, so it doesn't help us with diagnosis. So really, you're not going to diagnose Dravet in a young adult unless you're really thinking about it, because many people have lots of people in their practice who come through who have lots of different seizures. And so I think the most important is a person with persistent seizures of multiple types and certain findings on neurological exam. To me, that would be the trick. And of course, if you can recognize it, then you can do genetic testing, right? And the real breakthrough came in, I think it was 2001, when it was recognized that Dravet syndrome was associated with mutations in this sodium channel gene, right? The SCN1A gene. And I'm sure you all have heard about that and think about that. There's still a bit of a challenge here, though, because SCN1A mutations are well known to be present in people with epilepsy who have all sorts of different types of epilepsy besides Dravet. They might have some things in common with Dravet in that they are can be associated with febrile seizures, but even not all have febrile seizures. And so there's a list, and the list is actually even longer than this now, because of clinical syndromes, things we see in kids and adults that could then have an SCN1A mutation. And so actually, it can be quite challenging if you saw a child, and I know I've had families say this, well, don't you think you should just do the genetic test in like every kid that's had 2 or 3 febrile seizures? Well, the problem with that is that there are some conditions in which a child will grow out of their seizures and not have any comorbid learning problems, cognitive or motor problems, but might have one of these mutations. Their parent might have the mutation and not have any medical problems at all. And so finding out about a mutation in a young child before it even looks like Dravet could be very confusing. I've had a couple cases where that's happened, and it's hard to know how to talk to those families, because I still don't really know what the disorder is. So I think there's probably ways around that, and as the genetics gets better, we can maybe figure it out better. But that's just to highlight where the challenges come in with that. Excuse me. So, not surprisingly, we did ask the expert panel, when should genetic testing be done? And actually, you can get this paper. Do you have a post-it on your site?
Yes, we do.
Okay, yeah, because we
put it on our website.
The journal agreed, since it was so relevant to families. Usually they charge investigators to be able to have it open access, but we got this one open access, right? Yeah, so you can read the paper yourself. There's a whole bunch of pages that describe the method of getting the consensus or whatever, but there's a lot of information about what the panel believed to be the case. Believed to be best. And I've kind of tried to summarize it here on this slide. So when should genetic testing be done? Well, when should it not be done? So we agreed that it was not indicated for children under a year of age who have only one febrile seizure, basically. But we said that actually if the febrile seizures are repeating, particularly if they're long or focal, meaning on one side of the body, then actually testing should be considered. But not mandated, but considered. We said that children aged 1 to 3 years who have who are developing seizures that are difficult to treat, usually absence or myoclonic seizures, and have a history of a febrile seizure, genetic testing for SCN1A should be done. And we said that in teens and adults who have basically the characteristics that I showed you on that other slide, so people who have the typical neurology findings when we examine them, have a certain way of walking, have drug-resistant seizures, that genetic testing should be done. And in that case, probably it doesn't make sense to do specific SCN1A testing, but rather to get an epilepsy gene panel. And that's how most people approach this anyways, but in some really depending on how you can get funding for your genetic testing, it's possible that in some places people might be doing specific, just looking for SCN1A mutations. But I'd say, and Dr. Andrade is an expert on this, and she can address this as well, and if you have complicated questions, I might defer to her. But I would say that in most places these days, people send a panel because they don't want to limit their testing to one disease. In case their clinical acumen is off, they want to make sure they've looked for some other conditions. So half of the document, the panel document, looked at diagnosis, and the other half looked at treatment, management in general. I'm going to talk about seizure treatment now. So it was concluded by the experts, it was consensus concluded that complete seizure control is often not achievable. And the panel felt quite strongly that the highest priority is to control the prolonged convulsive seizures and obtundation status. And actually, it's important to point that out, because I more historically than now, I think, but I do know that there have been circumstances in which children or young adults are allowed to have continued non-shaking seizures because people have felt that maybe those are less dangerous. But I think when we see a person who is having hours of in and out seizures, even if their body isn't shaking, it would certainly be our recommendation that those be treated and stopped. But we need to remember to balance seizure control with treatment adverse effects, and families teach me that all the time, because you're the ones that really understand how the drugs that we prescribe affect your children, with a goal of maximizing development, safety, and quality of life. So it is a balancing act, isn't it? And it's hard for, I think, families who are new, not even specific to Dravet, but newly learning to cope with drug-resistant seizures, to come to an understanding over time that we can pick what kind of circumstances warrant an emergency room visit and IV anticonvulsants, and what kind of circumstances maybe warrant some home treatment or some wait and see. And that is such an individualized thing, and I think we all work with families trying to figure that out. And you guys for sure become the experts in it. In fact, like when the residents call me when I'm on call and say, this mother called and she says, should she go to emerge or whatever? And usually I say, well, what does the mother think? Because and truly, they know their kids best, right? But trying to work out this balance, that's tricky and it takes time, right? We don't have rules for that. It's individual. So we did come up with an optimal treatment algorithm, and it's listed here. And I hope that it becomes, or it is adopted by people treating children with seizures. I see people taking pictures, but the paper is freely available, so you can always just grab it yourself, and it's right in there. And really, this was a lot of hard work, talking to the experts over and over and over, trying to figure it out. But this is the agreement. So first-line therapy to be valproic acid or clobazam. And then if that doesn't work, try the other. So try valproic acid. If it doesn't work, then try clobazam, so back and forth. And then second line therapy, if that's not working, could be either the addition of stiripentol, which that people felt strongly that, it needs to be used with valproic acid and clobazam. And so that's why, this is a nice thought, but it can become tricky because you have a person on one and then you say, well, should I add the other and then add the stiripentol? So it can become hard. Some of the data actually that came out of Elaine Worrell's study showed, at least in her cohort, that stiripentol with clobazam, I think it was her study, was equally effective to stiripentol with valproic acid. But there's other studies that show that you need the three together. So anyways, addition of stiripentol to valproic acid or clobazam, or try topiramate, or try the ketogenic diet. And there's all sorts of caveats here, right? Because the ketogenic diet isn't for everyone. There might be kids who shouldn't be on topiramate for some reason. So, it's always individualized. That's why there's a lot of ORs. But it's this idea that to give doctors and nurses who are treating these kids, to give them some guidance as to how they should be thinking. And then if these things aren't effective, or if, for example, the diet isn't an option, so you've tried these things, then considering the addition of really at this point we don't have a lot of evidence. So any of these drugs have been shown in some series to be effective in Dravet syndrome, but not one kind of more than the other. Or consider a vagus nerve stimulator. And so just very briefly to touch on stirpental, because this is obviously a unique medication for Dravet syndrome. This started when there were two actually quite small randomized controlled trials. So that means that they took people with Dravet syndrome and they randomized them to either receive the drug or receive controlled, like a placebo. Sorry, I couldn't think of the word, a placebo. And they actually found that 70% of the patients in that study had more than a 50% reduction in the number of seizures they were having, which was pretty impressive for kids who had failed a lot of drugs, or who drugs had failed them, I should say, and who were having a lot of seizures. So that's a very meaningful endpoint. And in fact, even more impressive was that 30% of the people in that trial stopped having generalized tonic-clonic seizures if they were also on valproic acid and clobazam. So that's where this like golden cocktail comes from of valproic, clobazam, and stirpental. And then people have there's been multiple case series after that, but this is the most kind of experimental data comes from those small controlled trials. But other than that, there's been multiple series in the literature reported that have confirmed that using these drugs together seems to be the best kind of cocktail for Dravet syndrome. Other studies have shown that the seizures were shorter, or not even the seizures were shorter, that there were less long seizures. So the number of seizures that required an ER visit, required a rescue drug. So less rescue drugs, less ER visits, less long seizures, and a reduction in other types of seizures too. So less absence seizures, less myoclonic seizures. And so obviously that's exciting, and that's why for many people with Dravet, they are using stirpental. It brings up the question of what does stirpental do and why is it so effective? So I'm definitely not going to get into that in any detail, but just to say that it works on one of our inhibitory neurotransmitters. It works on the system of that neurotransmitter, and that's the way that the brain, it's through that system, the GABA system, that the brain shuts off a seizure. And so having enhanced inhibition in the brain is one approach to treating uncontrolled seizures. But the other thing it does, and this is interesting, is it inhibits something called cytochrome P450. And that is a system that is in the body to help break down drugs. And so cytochrome P450 breaks down clobazam, and stirpental inhibits its ability to break down clobazam. So some studies have shown that there is an increase in clobazam levels when a person is taking stirpental at the same time. And the reason that's important is because it probably doesn't make it, first of all, maybe that's why stirpental works, although it's got to be a combination thing, because just upping the clobazam dose is not as effective as adding stirpental to clobazam. But it does tell us why you need to use, you get the benefit when you use stirpental and clobazam together. And in my practice, I tell families that and I explain that, and that's why I don't want to just start them on stirpental. I want them to be on at least clobazam at the same time, if not clobazam and valproic acid. We also talked a little bit about the non-medical treatments in our consensus document. We talk about surgery specific for Dravet syndrome, and I work a lot in the surgical area for epilepsy, and we like it when we are able to help children by removing an area of the brain causing seizures, and that's called resective epilepsy surgery because we're resecting a piece. But for people with Dravet syndrome, that's not really an option because the seizures aren't coming from one brain region, so we can't isolate a region in which taking it out would improve the seizures. So the surgical intervention that is an option for Dravet is the vagal nerve stimulator. The vagal nerve stimulator, I'm not even going to get into it now, but it's an implantable device that it's not brain surgery. It goes in the chest, a wire goes in the neck, and it stimulates the nerve in the neck and sends messages up to the brain, or electrical stimulation up to the brain. There are a host of small studies reporting, 20 people, 30 people, something like that. And it does appear to offer benefit to people with Dravet syndrome. So I think if the other treatments, as we indicated, I think it should be considered a third-line therapy, and that's what we said in our consensus document. The other thing, which is a second-line therapy, is the ketogenic diet. Now, the ketogenic diet is a high-fat, low-carb diet that is been shown in randomized trials to be effective for reducing seizure frequency, predominantly in children with epilepsy. It also can be effective in adults. The reason it's used less in adults is really because of it's a very strict diet, and it's hard to convince adults to take it. But in adults who have cognitive impairment and are cared for by highly devoted parents at home, there's certainly no reason not to use a ketogenic diet in adults, so long as you have proper monitoring in that. And we have experts on the ketogenic diet sitting right over there from Matthew's Friends, and thank you for being here. And if you have questions about the diet, you can talk to me, because I like talking about the diet. You can also talk to our Matthew's Friends people, who will be out there at lunch, standing by their desk. But let's just talk briefly about what it does in Dravet syndrome. So the data, I've listed a few papers down there in the corner, but the data on the ketogenic diet in Dravet syndrome shows that between 60 and 70% of children treated with the ketogenic diet have that 50% or more seizure reduction. So that's a good outcome, and it's not dissimilar from what we see in people with other epilepsy syndromes treated with the ketogenic diet, but that's a lot better than adding another med. We don't see that when we start getting into the that list of meds that I said there's kind of moderate evidence for. And so for that reason, we put it as a level 2 recommendation. The studies have also reported less episodes of status epilepticus, even that the EEG can improve, which is interesting because we don't always see that with the ketogenic diet. Sometimes people get better, but in epilepsy, we improve seizure control, but we don't always improve the actual EEG patterns. And there's papers that show that there's benefit to using the ketogenic diet in association with stiripentol valproate and clobazam. And then over time, we like the diet because if seizure control improves, we can sometimes wean children off medications. And the benefit to that is coming back to that balance of seizures versus side effects of meds, quality of life, and cognitive profile. And so we like it if we can reduce medications that aren't contributing significantly. And one study also demonstrated reduced hyperactivity and improved behavior. We see that in people not with Dravet as well who are on the ketogenic diet.
Excuse me, Dr. Donner, I have my light on.
Yes.
We're gonna cut you off in about 2 seconds.
That's fine, no problem. Yeah, it's no problem. This is just to show one way of looking at this, which is that you can kind of compare the ketogenic diet, VNS, stiripentol valproic acid, and this is just to show that in at least this one study, which was less than 50 kids, but that actually stiripentol valproate and clobazam were still a little bit more effective than ketogenic diet, just as an example. There's also recommendations about acute seizure treatment, and this is all pretty straightforward, so I'll just skip through that. And then the last thing that I wanted to talk about was seizure triggers. And I'm going to show you 2 slides about this, and then I'm actually done. And what I wanted to, we talked about with our consensus panel the process of avoiding seizure triggers. And we thought one of the recommendations was actually to point out that no strategy is always effective. And so avoiding seizure triggers is individualized, and it may help or it may not help, but many children will have seizures even when you do your best to avoid seizure triggers. Things that were deemed to be helpful in most patients are listed there. This is things like avoiding high temperature, napping, avoiding overexertion, using antipyretics, which is medications that bring fever down, like so Advil, Tylenol, that kind of thing, at times of vaccination and illness, and at times of febrile illness, giving benzodiazepines. So that's like lorazepam, diazepam, midazolam. And for some people, those things listed there might help. And then the committee felt strongly that it was not recommended to avoid immunizations or to perform selective immunization, which is not picking and choosing which shots to get. And really, that's because the risk of those vaccine-preventable diseases outweighs the risk of having seizures at the time of a vaccine. No one's saying that they're not at risk of having a seizure after receiving a vaccination. That's why we're saying give the anti-fever medicines, watch your child very, very closely. But actually, they're going to be at a really big risk of seizures if they get some of these diseases like pertussis. I know of some cases of rubella now because of vaccine avoidance. So we highly endorse continuing with vaccines and also not taking antibiotics every time a person has a fever. So that's it. I am done. Those are my concluding statements, but I'll just stop there. You can read them. Thank you, Guida.